Uh, Namaskar, hello everybody to today's webinar. And today we have a very special guest, and we'd like to welcome Dr. LISE PIQUILLOUD. She's from Lausanne University, Switzerland. So, ma'am is ICU physician and clinical researcher affiliated to the Adult Intensive Care Unit, Lausanne University, Switzerland. She is a senior lecturer at the Lausanne Biology and Medicine faculty. And very importantly, she is course director for the Esicm transition course on mechanical ventilation. And she heads the Esicm acute respiratory failure section. So we welcome you, ma'am, to our webinar. We are really proud and happy to have you with us, and it's indeed a privilege. Thank you, ma'am, so much. Thank you very much.
Thank you for this kind introduction, and thanks a lot for the invitation. It's a great honor to be here today with you. Then we are going to speak of something that is a bit unusual in mechanical ventilation practice. We are going to speak about some alternative modes of delivering mechanical ventilation, particularly for assisted ventilation. And shortly, we are going to discuss NAVA and PAV, proportional modes, and then asynchronous modes, APRV and BIPAP. And to start, I would like to say some words on what is conventional assisted ventilation, the ventilation we use every day. Then under this word, I think we can put three basic modes: volume assist control, pressure assist control, and pressure support. For all those three standard modes of mechanical ventilation, we have two very common criteria or common feature. First, the same level of assist is delivered at each breath. And this level of assist that is delivered at each breath is set by the clinician and is not related to the patient's demand. This is something very typical from the conventional assisted ventilation modes. And the second thing that is common to all those conventional modes is that we try to obtain the best possible synchrony between the patient and the ventilator. And the special modes we are going to discuss do not share all those typical criteria of conventional assisted ventilation. And when we speak of those non-conventional modes of assisted ventilation, we can split them in different groups. And one of those groups is proportional assist ventilation, or proportional ventilation in general. And under this word proportional ventilation, we have two different modes: neurally adjusted ventilatory assist first, and proportional assisted ventilation second. The difference between the two is that the signal that is used to deliver proportionality is not the same. For neurally adjusted ventilatory assist, ventilation is delivered in proportion to the amplitude and timing of the neural command of breathing. Oppositely, in proportional assisted ventilation, the ventilator assistance is delivered in proportion to the effort, the inspiratory effort of the patient, which is directly correlated to the muscle, inspiratory muscle contraction. Those two modes are thus not the same, but they share something that is essential, and this thing is proportionality. And proportionality means that the amount of assist that is delivered by those types of modes is proportional to what the patient asks for. And this is very different compared to the standard mode of assisted ventilation, in which a fixed amount of assist is delivered at each breath. Now I'm going to discuss a bit more in detail, first NAVA and then PAV. And finally, we are going to discuss other modes that are totally different and Those are non-synchronous modes. To start with proportional ventilation, let's go to neurally adjusted ventilatory assist. Then the basic principle of neurally adjusted ventilatory assist, or NAVA, is to record the electrical activity of the diaphragm. Why? Because the electrical activity of the diaphragm reflects the activity of the brainstem respiratory centers. The reason for that is that breathing, the action of breathing, is initiated in the brainstem respiratory centers. Action potential that are generated here by pacemaker neurons are then transmitted to the inspiratory muscles, here in green, through the respiratory motor neurons. And at this level here, at the muscular level, depolarization occurs on the cell membrane, and this depolarization leads to muscle contraction. And by recording the depolarization, the electrical activity at the level of the muscle cells, we, in fact, record something that is in direct relationship with the brainstem respiratory centers. Then NAVA records this electrical activity as a surrogate of the brainstem respiratory centers activity. And this recording is performed using a specialized nasogastric tube that is equipped with electrodes here, 8 arrays of electrodes. And those electrodes catch the electrical activity, and here we see the raw electrical activity of the diaphragm. Then the system allows advanced signal treatment to filter ECG, because the heart is very close from the diaphragm, and also to smooth the signal to obtain what is called EADI for electrical activity of the diaphragm. And this EADI allows monitoring the activity of the respiratory centers and can also be used to pilot the ventilator. And this is NAVA. And in NAVA, this electrical activity of the diaphragm that is displayed here in the bottom line, you can see here in white the electrical activity of the diaphragm. And with NAVA, this signal is used to trigger the ventilator. As soon as there is an increase in the electrical activity of the diaphragm, the ventilator starts pressurization. Then this signal can be used to deliver assist in proportion to the amplitude of the electrical activity of the diaphragm. And you can see that the shape of the airway pressure curve here is very different compared to pressure regulated mode. It's not square, but it's really following the shape of the electrical activity of the diaphragm. And finally, with NAVA, the electrical activity of the diaphragm signal, the EADI, is used to manage the transition from inspiration to expiration. Then this replaces the usual expiratory trigger based on decrease of inspiratory flow we know in pressure support, for example. Then in summary, in NAVA, the electrical activity of the diaphragm pilots the ventilator, and we can describe that as a situation where basically the brain of the patient pilots the ventilator directly. And we can expect that we can obtain a good patient-ventilator synchrony doing this. We'll see that, in fact, it's the case. How to do in practice? Then to deliver NAVA, we need to have the dedicated nasogastric tube and the system required to filter and treat the signal. Then first, you have to insert the nasogastric tube. You can measure the nose-ear processus xiphoid distance as usual for placing a nasogastric tube. Then there is a formula to estimate where or to which length the tube has to be inserted. And then you can pre-visualize on the ventilator screen to see whether the electrodes are correctly positioned or not. And if you have the electrical activity of the diaphragm that is in blue in the middle, and if you see the P wave of the ECG decreasing from up to bottom, here you have a big P wave, smaller, even smaller, and not here anymore, you can say that the nasogastric tube is properly placed and can be used to switch to NAVA. And if you don't have the electrical activity of the diaphragm in the middle lines, as it's the case in those two examples, this means that the nasogastric tube is not properly inserted and that the electrodes are not placed at the right place in the diaphragmatic area. And here you can see that the electrodes are too deeply inserted. Then you only see them here. And oppositely, when the blue lines are in the bottom, this means that the catheter is not deep enough. Then it has to be changed to have a good signal to be able to deliver a neurally adjusted ventilatory assist. Of course, this requires some training, but it's not so complicated in practice. Now, how to set NAVA? Because basically, you just have to switch the ventilator to the mode, and then the system is going to catch the electrical activity of the diaphragm and is going to pilot the ventilator. However, there are things you can parameter. First, there is an inspiratory trigger that is based on the EADI amplitude change. And basically, the idea is to put the lowest possible value while avoiding auto-triggerings. And usually, the by default value of 0.5 microvolt is okay, and you don't have to change it. Regarding expiratory cycling, you cannot select anything with NAVA. The system is automated, and the system is going to switch from inspiration to expiration when there is a decrease on EADI value at 70% of the maximal value. But this is fixed, and you cannot set that. Finally, you can set a proportionality factor, which is the NAVA gain or NAVA level. And this proportionality factor represents the proportion of airway pressure you are going to deliver compared to the amplitude of the electrical activity of the diaphragm. I'm going to come back to that a bit later because it's important to discuss how we can set this NAVA gain or level. And in the end, you set FiO2 and PEEP as usual. Then let's come back to this story of setting the NAVA gain or level. As said, the NAVA gain or level is the proportionality factor between EADI and the delivered pressure. In the example here, in the bottom, the gain is set at 1, which means that for 1 microvolt of EADI, you deliver 1 centimeter of water of pressure. The maximal value here of the electrical activity of the diaphragm is 10 microvolts, and this means that the maximal amount of pressure the system is going to deliver with a gain of 1 is 10. If you now put the gain at 2, you see that for the same maximal value of 10 microvolt of EADI, you are going to deliver 20 centimeters of water. And this is the gain. Of course, when you change the gain, you also change the amount of pressure you deliver for a given electrical activity of the diaphragm. This is going to impact tidal volume. This is going to be detected by the baro and chemoreceptors of the patient. And this is going to create a feedback to the brainstem respiratory centers, which is going to influence the next EADI. This means that you cannot really set the amount of pressure you give to your patient, because this always depends on the feedback from the periphery, chemo and baroreceptors to the brainstem respiratory centers. How to set this gain or level? Then we could imagine to set it to target a given tidal volume or respiratory rate. We can do that, but as illustrated here in this paper for paternity, This way to do is not very precise because the range of NAVA level, precisely because of this feedback on the respiratory centers, is very wide for the same respiratory rate and tidal volume. Here, in the right upper part, you can see, for example, that for a NAVA level from 0.5 to 4, you have nearly the same respiratory rate in those patients. And same thing for tidal volume. You can see that independently or nearly independently from the NAVA level you set, you have the same tidal volume. Then this is not the right way to do, or at least you are going to have a huge range of gain for the same output if you do this way to set the NAVA gain or level. Just to illustrate, this is very different with pressure support. With pressure support, when you increase pressure support, you decrease respiratory rate. And when you increase pressure support, you increase tidal volume, of course. Then we have to find another way to set the gain. We could imagine to set the gain in order to target the same peak pressure as we do in pressure support. This can be easily done with the ventilator because there is a preview system, and you can see here that you can select or change the NAVA level and see what you are going to obtain in NAVA when you are going to switch the ventilator to NAVA. Basically, this just takes the electrical activity of the diaphragm, multiply by the gain, and predict what is going to be delivered here in white. This is easy to do. This can be used when you just switch to NAVA from another mode. However, this cannot be used to set the gain during the next days because you don't have the comparison of the standard modes anymore. Then this is useful at the start, but then to adapt the gain, we have to find another solution. And in my opinion, what is the easiest to do is what was described by Adrien Rosé from Bordeaux in France some years ago. And the idea is to shortly suppress the assist to measure the maximal EADI the patient can deliver. Then you measure the maximal EADI and you adapt the gain to decrease this maximal value to 60 or 70% of the maximal value. And this allows setting the gain differently day after day, depending on the patient situation. In this example, Adrien Rosé did a spontaneous breathing trial in pressure support to obtain this maximal EADI, but we could also imagine doing that in NAVA just by putting the gain at the minimal value, then measuring the maximal EADI, and then increasing the gain again until you obtain a decrease in maximal EADI to 60 or 70% of the very maximal value. Easy to do. And my proposal, if you use NAVA, is to set the first gain when we switch to the mode based on the ventilator available system in order to target the same pressure compared to pressure support or pressure assist control you used before, and then to adapt daily the gain using the technique of Adrien Rosé by measuring maximal EADI without assist, as soon as you can shortly suppress the assist, of course, and then titrate the gain to decrease this maximal value to 60 or 70% of the max. Now, is it useful to use this type of modes, which basically is a very different way to approach mechanical ventilation compared to pressure support? Then for sure, NAVA improves synchronization. These are already old physiological studies we did a long time ago. And in the upper part of the slide, we have patients under invasive mechanical ventilation. It's a crossover study in 22 patients. And you can see that compared to pressure support ventilation, NAVA decreases trigger delay, improve expiratory synchrony by decreasing the inspiratory time in excess that represent the difference between the end of the inspiratory neural inspiratory time of the patient and the end of the ventilator-delivered pressurization. And even much more importantly, with NAVA, we had less asynchronies and less severe asynchronies. And on the right, you can see that NAVA suppresses ineffective efforts and delay triggering compared to pressure support ventilation. And this was the same for non-invasive ventilation. In the second study, we have the same type of design, a crossover study, 13 patients. And in those patients under NIV, you can see that compared to pressure support NIV, NAVA NIV decreased the trigger delay, improved inspiratory synchrony, decreased or improved inspiratory time in excess in nearly all the patients, which means improvement in expiratory synchrony, and asynchrony index was much lower with NAVA compared to pressure support. Then the system improves synchronization. And NAVA also improves sleep. You can see here a small study performed by Canadian colleagues, also comparing NAVA with pressure support ventilation. And you can see that in NAVA, in light gray, there was more stages 3 and 4 of sleep than deep sleep compared to pressure support ventilation, and also more period of time in REM sleep compared to pressure support ventilation with NAVA. And you can see that the fragmentation index, which is a way to express the microarousals, was much lower with NAVA compared to pressure support ventilation. Maybe even more interestingly, NAVA trained the diaphragm, and NAVA improves the diaphragm contraction efficiency, probably because it avoids delivering over assist. Here we have a small, very interesting study performed in 25 patients, and those patients who were switched to assisted ventilation were randomized either between NAVA or pressure support ventilation. And the authors measured every day during 2 days the ventilatory efficiency, and ventilatory efficiency is the relationship between tidal volume and EADI. Then this reflects the strength of the diaphragm or the efficiency of the diaphragm contraction compared to the neural command of ventilation. And as you can see in NAVA, this efficiency of the diaphragmatic contraction increased very early, already after 1 day, compared to pressure support ventilation. And this suggests that such a system can be interesting to train the diaphragm in the weaning phase of mechanical ventilation. Of course, these are small physiological studies, but the concept behind the use of those proportional modes is of great interest. Now we have some big studies to discuss with NAVA. Then first, this is the first randomized multicenter studies performed with NAVA already a long time ago, nearly 10 years now. 128 patients included intubated patients, and these were general patient population in the ICU with very few COPD, less than 20%. And this study showed that the technique is safe, can be used during a prolonged period of time without any problem, allowed to keep patients under assisted ventilation, as it was also possible, of course, with pressure support ventilation. Overall, this study confirmed that NAVA improved patient ventilator synchrony. However, there were no differences in the duration of ventilation, ICU length of stay, or on mortality. Then overall, on the major outcomes, this was a negative study. However, there are a lot of things to discuss about this study. First, the population was a very general population without a lot of asynchronies, and it was potentially very difficult to show any advantage of NAVA in patients who were ventilated only during a short period of time after inclusion. In addition, the centers that participated to this study were expert centers in mechanical ventilation, and basically pressure support ventilation was optimally set, especially with very low pressure support levels in patients who, in addition, were not very sick, And there were very few asynchronies in those patients during pressure support ventilation. Then again, the expected advantage of NAVA was relatively low in this specific population. And finally, and this is maybe the more important limitation of this study, the electrical activity of the diaphragm was displayed on the screen also for the patient in pressure support ventilation. And we can clearly imagine that having the electrical activity of the diaphragm on the screen could have influenced the ventilator settings during pressure support ventilation. For example, if clinicians show a very low amplitude electrical activity of the diaphragm, this is strongly associated with over-assist, and we can imagine that clinicians who were expert clinicians in mechanical ventilation could have decreased pressure support in this situation. Then again, this study is negative on the main outcomes, but probably that the population was not the right one. And in addition, that there are a lot of limitations that could explain the absence of difference. More recently, we have had a new multicenter study on NAVA. This time, it's not the same patients. It's patients who were already ventilated during 5 days, more than 300 patients. And we have NAVA compared to standard protective ventilation. This is a randomized study. And in those patients who basically were much more sick compared to the patients of the previous study, the authors showed that using NAVA was associated with more ventilator-free days at 28 days. Clearly significant result. However, again, there was no difference in mortality using NAVA or pressure support ventilation. Now, another study, which is a small study. It is a feasibility study that was done for a future big randomized control trial. This time we have 78 intubated patients who are at risk of being difficult to wean from mechanical ventilation. They are either COPD patients, patients with ARDS, or patients who have cardiac failure. Again, randomization between NAVA and pressure support ventilation. And as you can see, as secondary outcome, the authors assessed the ventilator-free days, and again, the number of ventilator-free days, both at day 28 and at day 90, are much higher in the NAVA group compared to the pressure support ventilator group. And in this small study, again, a secondary outcome, we even have a signal on hospital mortality in favor of NAVA. Then this clearly keeps the way open for those type of modes, maybe in selected patients, in patients who can really benefit for the technique. We could imagine having an impact on outcome, even if this still has to be demonstrated in big randomized studies. Now, we are going to discuss the other proportional mode, which is PAV, proportional assist ventilation. Then this time, the amount of assist is not proportional to the electrical activity of the diaphragm, which means to the respiratory center's activity, but the amount of assist in PAV is delivered in proportion to the strength of the inspiratory effort. How does it work? Then basically, the system continuously measures the flow and the volume that is delivered in the airways. It measures or estimates, depending on the system compliance and resistance, and based on all those information, the system assesses the inspiratory effort of the patient and delivers assist in proportion to this effort, which is the muscular pressure of the inspiratory muscles. I'm going to describe more in detail how it works. And the working principle of PAV is based on the equation of motion of the respiratory system. You probably all know this equation, which says that the total pressure that is present in the airway equals the pressure delivered by the ventilator, P airway, plus the muscular pressure, the P mass. And this sum of P airway plus P mass equals the flow times the resistance, which is the resistive pressure, plus the volume times the elastance, which is the elastic pressure, plus the initial pressure in the system at the end of expiration. And this is based on this equation that the PAV system works. How does it work more in detail? First, the system measures flow and volume instantaneously in the airways using the ventilator. Second, resistance and elastance are either estimated in PAV or measured with short inspiratory occlusion with PAV+, which is the more evoluted system or advanced system with PAV. Then the initial pressure can be considered as the PEEP set on the ventilator. This means that you know all those parts of the equation, and users know the total pressure. And then the system selects the proportion that has to be done, proportion of this total pressure, that has to be done by the patient and by the ventilator. And for example, if you set the system at 50%, it means that the patient has to do 50% of the total pressure, while the ventilator delivers the other 50% of this total pressure. And this is the way how PAV works. Another example here, if you set the system at 75, gain of 75, this means that the ventilator is going to deliver 3/4 of the amount of total pressure, while the patient is going to do 25% of the total pressure. And by combining a bit the different equations, you see that the airway pressure is proportional to the muscular pressure generated by the inspiratory muscles. And the relationship between the two is based on the gain, which is what you set on the ventilator, and which represents this proportion of what has to be done by the patient and by the ventilator. On the ventilator screen, it looks as this, and you can observe here that the system estimates the part that is done by the patient and by the ventilator, and by selecting the gain, you can change this proportion. Very practically, we have tables to set the ventilator. I'm going to discuss that a bit later. There are also other things you have to set with PAV. You have to set the inspiratory trigger as usual. It is a pneumatic trigger, as you know, in pressure support ventilation. The expiratory cyclings is based on a set flow and not on a decrease. And usually the by default value of 3 liters by minute is okay. The gain, I'm going to come back in the next slide, and FiO2 and PEEP you can set as usual. If we just shortly come back to setting the gain in PAV, the idea is to assess the muscular pressure or to estimate the muscular pressure of the patient, and then to set the gain in order to target a muscular pressure in a normal range. Then the system is a bit complicated, but we can shortly explain. And first, the system uses peak airway pressure that is displayed on the ventilator screen, PEEP that you know, and uses those values with a table. I've not put here, but I gave you here the reference, which is the one from Guillaume Carteau from France. And using a table, you can know based on what you have on the ventilator screen, what is the expected patient effort. And based on this expected effort, you can then select the percentage of assist that has to be delivered by the ventilator. Is it useful to use PAV+? Then again, we have some small physiological studies suggesting that the system can be of interest. Here, a randomized study with 16 patients, and you can see that with PAV, compared to pressure support ventilation, there were less asynchronies, and also improve sleep quality, exactly as we saw with NAVA, with increased in the REM sleep, increase in stage 3 and 4 of sleep, deep sleep, and less arousals and micro-arousals with PAV plus compared to pressure support ventilation. Another crossover study here that basically shows the same on patient-ventilator synchrony. PAV plus improve expiratory synchrony a lot, and overall PAV plus increases the time with good synchronization between the patient and the ventilator compared to pressure support ventilation. Another study here, a bit bigger one, 50 intubated patients, comparison between PAV, PAV plus and pressure support ventilation. And again, you have a clear trend toward less asynchrony with PAV plus compared to pressure support ventilation. And this even remains true after optimizing the pressure support ventilation first. Regarding multi-center randomized study, there is one that is going to be published soon, I hope. It's the promising study, and we'll see the results. This study is an outcome study. Very interestingly, this is a paper published a bit more recently by the team of Guillaume Carteau once again. And they looked at patients who were difficult to synchronize. Then they took patients who still had all the steps performed in pressure support ventilation to improve patient-ventilator synchrony. Everything was changed. Pressure support was adapted. Expiratory trigger was improved, etc., etc. And those patients still had ineffective efforts. And you can see that switching them to PAV basically resolved the issue, because with PAV, there were nearly no asynchrony anymore in those difficult to synchronize patients, which is clearly an interesting result, confirming that this type of system can definitely improve patient-ventilator synchrony. And interestingly, there are other things that can be done with proportional modes, both NAVA and PAV plus. They deliver assist in proportion to the patient demands. And that means that those systems avoid limiting or avoid or permit limiting over assistance. And as you can see here, in high assist level, even if you increase the gain in NAVA and PAV, you do not increase tidal volume. And this is not the case, of course, with pressure support ventilation. With pressure support ventilation, if we increase pressure support too much, you increase tidal volume. Then the proportional modes avoid this over-assist, even in the highest levels of support, which probably is of interest to avoid diaphragmatic atrophy, for example. And interestingly also, you have here the variability coefficient of variation of the tidal volume. And as you can see, during pressure support, the variability of tidal volume is very small and is much higher with the proportional modes. And as physiology is variability, and because there are data suggesting that maintaining variability in the system of assist is better because closer to physiology, we can also imagine an advantage of proportional modes by maintaining this respiratory variability. But again, this has to be proven by further studies. Then this was about proportional assist ventilation. Now, I would like to discuss another non-conventional or special mode of assisted ventilation, which is APRV BIPAP. Here, the story is completely different. It's not proportional assist ventilation. The amount of assist is always the same, but what is particular or special here is that patient-ventilator synchrony is not the aim anymore compared to standard modes of ventilation. Then the general principle of those modes is that they are pressure regulated modes. High pressure, low pressure. And the transition between high and low pressure is based on a time value, inspiratory time. The second point is that the patient can breathe spontaneously, not in relationship with the delivered or mandatory breath, independent spontaneous ventilation. And there is no synchronization, which means that the patient cannot trigger the ventilator. The patient can breathe, but cannot trigger the ventilator. And this is very special compared to the standard modes of ventilation we use. Now we have two different settings of this mode. We have the APRV setting and the BIPAP setting. In APRV, the idea is to have very prolonged period of time with high pressure and very short period of time with low pressure. The idea here is to create some auto-PEEP and to recruit while having a patient who can breathe spontaneously. Oppositely, in BIPAP, the idea is the same. There is no synchronization, but the I/E ratio is conventional, for example, 1/2. You don't have the inverse ratio as you have in APRV. Then it's totally different. With BIPAP, you cannot really recruit more than with another mode, but you can have spontaneous ventilation in addition to an alternance of 2 levels of pressure support. Here, illustrated with some schemes, you have the BIPAP first, then you have conventional I/E ratio, meaning that expiratory time is bigger compared to inspiratory time. The patient can breathe on both the low and high pressure. You can see that in the bottom part of my figure. And there is no synchronization. Then the ventilator does its alternance between high and low pressure, and the patient breathes both on the low and high pressure levels, but without having any synchrony between the patient and the ventilator. Just here to illustrate how to set this type of modes, on the right you have standard pressure control, on the left you have BIPAP. Then you have to select the high level of pressure based on the tidal volume you want to have, the low level of pressure, basically it's PEEP. Then you have to select the duration of the inspiratory time, the duration of the expiratory time to have the I/E ratio you want to target, which is conventional, and indirectly users set the respiratory rate. Now APRV, then APRV is inverse ratio ventilation. As you can see in this illustration, in APRV, the duration of the high pressure, the inspiratory part of the breath delivered by the ventilator is very long, and the expiratory part, low pressure, is very short. Again, the patient can breathe both on the high and low pressure value, and there is no synchronization, which means no pressurization that is delivered in response to a patient effort. And with this type of mode, because you have a very short time for expiration, you generate some amount of auto-PEEP, and you thus have some recruitment. Be careful, because you still have to avoid too much auto-PEEP, and it's just important to understand that. You have here the effect of having a very short expiratory time, and you can see that in light blue, we have the situation where there is no flow restriction, because we imagine that the duration of expiration is big enough. And if we shorten it a lot, you can see that we have a limitation of expiratory flow, and for each breath, we have some volume that is trapped in the alveoli. But if this time is really too short, then we have an increase of the intrinsic PEEP, and finally of the end expiratory volume. And we can use this concept to set the duration of the expiratory time. I'm just going to show you that in the next slide. We have during APRV either a passive patient on the left, who just alternate between the two levels of pressure delivered by the ventilator, and you can also have a patient who is breathing spontaneously. Basically, you have the same, and in addition, you can see the patient effort that is displayed here by each P mass curve, and you can observe that for each P mass of the patient, you have a patient effort on the airway pressure curve here. How to set this APRV? Then you have to select the high pressure value. Usually we target the same P-plat as during other modes. You have to select the low pressure value. Basically, you need to have a very low value, lower than usual PEEP, to allow a difference between a high and low pressure to allow expiratory flow. And then you have to select the duration of the inspiratory and expiratory phase. And one way to do in a restrictive patient is to look at this decrease in flow during expiration and to target a flow that is decreasing up to 50 or 75 of the peak expiratory flow to avoid too much hyperinflation. I personally do not use APRV in severe patients because I'm afraid of not being able to control the amount of air that is trapped in the alveoli, but some other teams use the system this way. Is it useful to use those type of techniques? Then we have, again, physiological data. APRV with the inverse ratio improves recruitment, oxygenation, and hemodynamics. You have here 24 patients with ARDS, and they were ventilated either with APRV or pressure support ventilation. And with APRV, compliance was better, oxygenation was better, cardiac index was higher, and oxygen transport and extraction were also improved. More oxygen transport and less oxygen extraction. And overall, the authors also demonstrated an improved ventilation over perfusion ratio, which was explained by both a decrease in shunt and dead space. And here, another study, also a physiological study. This time, we have 30 patients with polytrauma. They were randomized in APRV or pressure-controlled ventilation. And again, with APRV, compliance was better, oxygenation was better, cardiac index was improved, oxygen transport was improved, and oxygen extraction was needed. And interestingly, there was also less need for sedation in the APRV group in this study. Finally, in this small study, you can see that APRV was associated with a decrease in the length of ventilatory support and also of ICU stay. However, small study, and of course, this has to be confirmed in bigger studies before being considered as possible standard of care. Here you have also the effect on oxygenation, which is relatively clear in favor of APRV in this set of patients. Regarding BIPAP in conventional ratio ventilation, we don't have a lot of data. The study was published very recently by Richard and collaborators in ARDS patients, and they showed that less sedation was required with BIPAP ventilation, that this was clearly feasible in the acute phase of ARDS. Unfortunately, in this recent study, the patients are still quite deeply sedated, and there is very few spontaneous breathing in the early days, even in the BIPAP group, and probably this explains why they could find any advantage on outcome in this recent study. In conclusion, non-conventional modes exist to deliver assisted ventilation. These non-conventional or special modes of ventilation have physiological advantages. This is very clear. Using these modes require thinking differently. It's not standard mechanical ventilation, and this might sometimes be very challenging for us, ICU clinicians, and for our teams. And additional multi-center studies are required before concluding to clinical advantages in terms of outcomes of these modes. The physiological rationale, once again, is strong. The evidence is still lacking to be able to recommend those type of approach as standard of care. Stan, thank you for the attention, and I'm happy to answer to your questions.
Thank you, Dr. Piquilloud, ma'am. Wonderful lecture. So nice hearing about all this. And we request the audience to put up their questions if they have any. Ma'am, can you stop the share screen, please?
Yes. I try.
Yeah, that's okay. Thank you, ma'am. So request the audience if they have any questions. So far, there are no questions, ma'am. So maybe I can just put up some points for discussion. So, ma'am, first of all, these modes, the alternative modes have been around for many years. In fact, some of them go back to 10, 20 years, and still they are not in common use. You said in the last slide, it requires thinking differently and more data is needed. So first of all, ma'am, what is your experience with these modes?
Yeah, thanks for this question. Then, as you say, those modes are not new, for sure not, and they are not widely used. The first reason for that is that they are very different, and that we have to change our way of thinking mechanical ventilation, and this is not easy. And big studies are still lacking. But the problem is that it's not so easy to implement those modes in standard practice. And for this reason, it's not easy to do big studies. In my personal experience, we use neurally adjusted ventilatory assist, especially in the very difficult patients, those patients who cannot really be synchronized, and this works very well in those very difficult patients, but it's more case reports than big studies. I have no experience in the clinical work with pressure with PAV or PAV plus. I've used it in experimental settings, but not in patients. But it works also, but requires a dedicated ventilator. And if you don't have the ventilator, then you cannot use it. And this is also one limitation. And finally, regarding APRV BIPAP, as I said, APRV per se with inverse ratio, personally, I'm not using it. But I use BIPAP in conventional IE ratio, sometimes in patients who are very difficult to transition from controlled to assisted ventilation. Particularly in the COVID period, with those patients who couldn't be switched to pressure support ventilation because of so many double triggerings, for example, I used this strategy, and it allowed to transition to pressure support later. And we are now starting in the unit a feasibility study to wean patients in BiPAP compared to pressure support ventilation, with the idea of doing a big randomized trial as a second step. Then I'm convinced that this type of approach can work, but again, we still need data. And regarding the other modes, I know that for PAV, the study is completed, but I don't know the results, the promising study. For NAVA, there is one big trial going on in the UK. And for APRV2 and for BiPAP, we are going to start one. Then I think we are going to see new data in the next years.
Thank you, ma'am. So that is about the trials, and like we need data. But overall, ma'am, with so much experience that you have, what is the future with this? Do you think we'll be using this? And as you said, these modes are also not available on the ventilators. So where are we going to go? If we don't have them on the ventilators, that itself restricts their use, right? People can't experiment and all that.
Yeah, and in fact, I think that for the moment, it's clearly okay not to use them because data are still missing. And for the future, probably that's what is the easiest to use are the APRV BIPAP modes because they are available in the majority of the ventilators. They don't have this name, but the concept is available in the majority of the ventilators. Regarding proportional ventilation, if it proves to be efficient in the future, we can imagine that this is going to come in other ventilators too. Because the fact that it's, for the moment, related to some ventilators is clearly a problem to widespread the use, for sure. But again, if we don't have those type of modes for the moment, it's perfectly okay. We can ventilate conventionally very well.
Thank you. So moving on to APRV mode, which you can set easily and is more accessible. And you showed data also, ma'am, that it improves oxygenation, it improves recruitment, less sedation, spontaneous breathing, better hemodynamics, and there is data to show in ARDS it might be better than conventional mode. There is some data, and I think this is the most common of the alternative modes being used. So what do you comment on that, on the use of APRV in ARDS vis-a-vis conventional modes?
I prefer the concept of BIPAP with a standard IE ratio because using APRV per se is really very, very different compared to usual practice. Using APRV with inverse ratio needs to have a great expertise with the mode because the risk of air trapping is really here. Then I would say to be very careful to use APRV. We really need to train all our teams for setting PEEP, which is very different, which must be very low values set on the ventilator because basically it's more auto PEEP that is important in this situation. And it's not easy to set and to monitor. And I would say be very careful with APRV. You need to train all your team before doing that in clinical practice. With BIPAP, with IE ratio of 1/2, for example, in my opinion, there is no risk. You just have a patient in a non-synchronous modes, but it's not dangerous. Then personally, I would prefer the strategy of BIPAP both during the acute phase and the weaning phase of ARDS, if I don't use standard modes.
So moving on to ma'am PAV and NAV. So NAVA. So ma'am, like you have also shown that both of them improve synchrony. And in the conventional modes, for example, in ACBC, we have asynchrony index of up to 30% and PCB 20%, while studies have shown, I think, less than 5 to 10% in PAV. So, and you also said you use them. So you would like to comment again, ma'am, or elaborate a little on the use of PAV where there is significant asynchrony?
Yeah, proportional modes really are very good to suppress asynchronies. This is very efficient. The point is that a lot of our patients do not have so many asynchronies. Then those standard patients do not really benefit from those different modes. Those modes, proportional modes, NAVA and PAV, are interesting in those patients who cannot be ventilated with standard pressure support because they are too asynchronous. And we can think of very severe COPD patients, sometimes asthma patients in the post-acute phase, and very, very restrictive patients at the transition phase from controlled to assisted ventilation. Then in those specific patients, if you have the proportional modes available, you can use them. It's not dangerous, and it can really improve patient ventilator synchrony.
Thank you, ma'am. So, ma'am, again, regarding the use of these modes, PAV and NAVA, they work in the same way. They improve asynchrony and they give proportional assist. However, and in fact, NAVA, one study, Navigator study showed there was a 35% reduction in mechanical ventilation duration also. So now, just comparing PAV and NAVA, in the sense that both are similar in their way they work, and also, they improve synchrony. But I think NAVA is becoming much more popular, while PAV is kind of very limited. So where is the difference, ma'am, in this? What is happening with NAVA and PAV?
Yeah, the way they work is a bit different. And basically, they clearly both improve synchrony. But if we look much more precisely, NAVA is better to improve inspiratory synchrony because the impact on reducing trigger delay is particularly good using the electrical signal. Then probably NAVA is even better to improve synchrony. And then regarding the usability of the system, setting NAVA gain or level is not very easy, but is easier compared to setting PAV level or PAV gain. Then from a very practical point of view, I think it's easier to use NAVA compared to PAV. Oppositely, the problem is that for NAVA, you need the dedicated nasogastric tube in addition with the ventilator. And with PAV, you just need the ventilator. Then from the point of view of the costs, it's more in favor of PAV. Then you have advantage for one and for the others.
Thank you, ma'am. So there's a final question, ma'am. Remember, there's the other mode is the adaptive supportive ventilation, ASV, which is also there. And that has its own advantages. So would you like to just touch upon it vis-a-vis, the conventional modes in the use of ARDS?
Interesting question. This could be the topic of another webinar because automated modes are something else I didn't touch today. Automated mode is closed loop ventilation modes that deliver ventilation in order to obtain targets. And based on the respiratory mechanics and the value that are measured by the ventilator. And the idea is really to keep a closed loop around the target. And this is ASV or IntelliVent. And those modes are effective, are safe. And there are some data suggesting that they could do at least as good as we do as clinicians, and maybe in some very specific situation, even better. But it's totally different modes, automated modes, and I didn't touch that today.
Thank you, ma'am. So I think there are no questions from the audience. It has been wonderful listening to your talk, ma'am. Thank you very much. And I would be putting this up on a YouTube channel for viewers from all across the globe to go through again and to view it. And I thank the audience for their wonderful participation. So any message for our audience, ma'am, especially the young ones, young intensivists, anything you like to tell them?
No, just continue being good doctors at the bedside and involved for your patients. And the better we understand physiology, the better we can treat our patients. And I think it's my key message.
Yeah. Thank you, ma'am. Thank you, Dr. LISE PIQUILLOUD, ma'am. Thank you very much.
Thanks a lot. Thanks for the invitation.
Thank you, ma'am.